Margaret. Thank you.
Okay.
Just to confirm, the meeting's now live, Chair.
Thank you. Good morning and welcome to the Primary Care Commissioning Committee meeting. I'm Margaret Geary, lay member, and will be chairing the meeting today. We're meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the NHS Portsmouth Clinical Commissioning Group website. And papers for the meeting are also available via the website. Today's meeting is being recorded so that in the event of a failure of technology, it can continue and will be uploaded onto the NHS Portsmouth CCG website as soon as possible. Agenda items that require a decision will be confirmed by a raised hand by committee members only. Prior to presenting their agenda items, attendees should state their name and job title and, where possible, turn on their camera. When I call your name, please turn your microphone on and give your name and title. I will call on committee members first and then attendees. I'm not sure everyone's here, but is it Helen Atkinson? Dr. Linda Colley?
Hi, I'm Dr. Linda Colley. I'm GP at East Shore and Clinical Leader for Health and Care Portsmouth.
Jason Eastman? Don't think he's here either. We've had apologies from Mark Compton, Simon Cooper, Julia O'Mara. Jackie Powell?
Morning, Jackie Powell, lay member. Thank you.
We've had apologies from Andy Sylvester, who's also a lay member. Do we have Nicola Burnett here? Yet? No. Jo York? I think Jo's due to join us, but she will be later. Okay. Can I then just check on Roger Butterbury?
Yes, Roger Batterbury, Chairperson at Healthwatch Portsmouth. Thank you, Margaret.
Okay. Lisa Harding? Claire Curry? Christine Horan?
Hi, Chris Horan, Primary Care Improvement Manager.
Dr. Will Howard?
Hello, yeah, my name's Will Howard. I'm a GP and I am a Medical Director of Wessex LMC.
Justina Jeffs? And Justina is with us, but at the moment is on silent. Sylvia Macy?
Thank you, Chair. Sylvia Macy, Acting Deputy Director of Primary Care.
Steve McGuinness?
Morning, Steve McGuinness, Head of Primary Care.
Stephen Arobio?
Hi there, Stephen Robio, Clinical Quality Manager, Portsmouth CCG.
And Lisa Stray.
Good morning, Lisa Stray, Executive Assistant to Business Services. Thank you.
Okay. Apologies for anyone I've left out who's here and I can't see, but we'll come back to that. Thank you. Can we then...
Just that, you know, you missed me out, Jo York, Managing Director of the CCG.
No, I think you weren't here when I called your name, Jo, so...
sorry, I had login problems, sorry.
Okay, thank you. Shall we then move to the Register and Declaration of Interests? Are there any conflicts of interest to be declared today?
As a GP, Margaret, I probably should just declare general interest. There's no direct conflicts today, but general interest in the item.
So most of these items you'll have an indirect interest in, but that doesn't stop you participating in the meeting. Thank you. Okay, can we then move to the minutes of the last meeting? Seems like a long time ago, in November. And if we look for accuracy first, page 1. Any comments? Page 2. I'll take silence as agreement. Page 3. Page 4. Page 5. And page 6. And page 7. There were several actions there. One was in relation to the refreshed primary care risk register, which is, I think, Sylvia, has been done. Yes, can you confirm?
Yes, thank you, Margaret. It has.
And there's a COVID vaccination risk factors, and I think an email was circulated post the meeting. Sylvia, is that right?
I think is there a post-meeting note on that one?
I thought there was. Yeah.
So I think it's completed.
Okay. And the question around vaccinations for antenatal, so in the antenatal clinics, where it was also there's a note being sent round, so they're all completed. Okay, thank you.
Margaret, Jackie's got her hand up. I don't know if she's got a question on that.
Sorry. Yeah.
Okay, thank you. My question on that was that I know that the vaccinations are readily available, which is great. Do we have any sense of how many actually take up the offer as a percentage, or is that?
Off the top of my head, are we talking generally or are we talking specifically, Jackie?
For the antenatal, because it's readily available, but I'll take any information that's available. But for that one, because it's available and it's quite an important, they're all important groups. I don't know if we had any actions around or knew what percentage of people actually took up the offer.
I don't know, but I can find out. So let's take that as an action that I will find out.
Thank you.
Okay.
Thank you. Sorry.
That's okay.
Okay. We've got the primary care risk register next. Can then move to that?
Yeah, thank you, Margaret. So this is the latest version of the risk register. I'm just going to pick up on a few of them, if that's okay, and then I'll see if there's any comments. So the first one is 05I, so it's the third one down, I think, around practices and the risk of not signing variations promptly for their contract. But we've worked with practices around that, and practices are doing that in a more timely manner now, generally speaking. So I think risk is reduced right down. In fact, we might want to consider removing it if other people agree. It's not really an issue from my point of view anymore.
Are people happy to remove this particular risk? Can I just see? Yeah, I see some nods, but yeah. Okay.
Great, thank you. Next one was C08. Bear with me. So this is around the risk of if practices were not adjusting their services adequately, there in light of COVID-19, it might put patients at additional risk. But practices throughout the pandemic have adjusted and been very flexible with the way they deliver services, obviously doing lots of remote consultations online, and they've had hot hubs at some points in time, and in other points in time they've had red rooms which they continue to use as necessary. So they've taken all the precautions, followed the infection control guidance. I don't think there's anything more that practice could have done, but of course with COVID circulating as it is at the moment, the risk is still there, particularly in light of changed guidance around face masks, etc. So it's just a question of whether we still feel this should be on there. I think practices have done all they can to mitigate, but the risk is still there really. So it's whether we feel we can lower it in light of all what practices have done. Happy to hear people's views on that.
Has anybody got any comments? No? Yeah, Jackie?
Sorry. Sorry, I'm playing catch up a bit here. I suppose it might have been, excuse me, linked to my first question. I know we've done everything to enable especially hard to reach communities to have a vaccination where it's appropriate. Do we have any figures on what percentage would have taken up their offer, or whether there is still further work to be done or have we done all that we possibly can.
I'm just going to dip in, Steve, if that's okay. Jackie, we do have numbers. I don't have them in front of me. Would you like us to bring something to the next meeting so that you can see what numbers and what cohorts, you know, age groups and distinct groups? Would that help so that you get a bit of sight on exactly how many people? I mean, the uptake is actually very good across almost every cohort. There are obviously some hard to reach people, especially within some areas of Portsmouth, but even so we are doing very well. But I just don't have the numbers off the top of my head, I'm afraid.
That's all right. It might be useful for me, because don't forget we get this at public board as well in terms of the overall numbers. Perhaps it was the hard to reach areas.
So would you like something circulated, or should we bring it to the next meeting?
If people don't mind, I'm quite happy with something circulated. It might just be me kind of causing a fuss.
No, you're getting, there are nods around the meeting, so I suspect other people are interested as well. Okay.
Okay, yeah.
Circulation.
I did have another one, if that's all right, Margaret. I don't know if...
Go ahead.
The risk that I was perceiving that I can't quite see here is perhaps around primary care transformation. So I'm wondering whether PCNs feel ready to take on the responsibilities that may be coming their way when the ICS is developed, and is that something that we feel we've got a handle on across the city, or something that could be potentially a risk to us and to the service?
I don't know whether Joe will want to come in about the ICS, but certainly there is actually a workshop tomorrow, Jackie, as it happens, in Winchester, which all our PCNs are going to, which Nicola Decker is leading for the ICS. So it's a good opportunity tomorrow for them to get together and have some discussions about the future. We've certainly shared the Hampshire and Isle of Wight primary care strategy, so people can digest that and start looking at that. But say Joe may wants to come in as well.
Joe.
I think obviously capacity for PCNs is a risk across the board, as it is for, you know, lots of other services at the moment, and capacity for them to take on all that is required of them. And particularly, you know, they've spent a huge amount of time over the last year or so delivering the vaccination programme, which has been hugely beneficial, but is another ask. So I think we're very cognizant of that. The work we've been doing around primary care improvement, which is still sort of developing, is looking at how we can support PCNs more effectively. And I think the other bit is also how the ICS and the strategy is then delivered and delegated, and we are still expecting that a lot of the work will continue to be delegated down to place in line with the ICS guidance. So it will be how we come together as a city, which I think we have a real strength in doing, but also then how we make sure that primary care voice is really clearly fed up through the ICS. And so I think we've got the opportunity to work with PCNs and our, you know, clinical execs here to think about how will that look in the future.
Thank you, that's really helpful. So it's not something that is a significant risk that needs to go in our risk table at the moment.
I don't think a specific risk about PCN development in light of the ICS is a specific risk. I think it's covered probably in the risk we've got around, you know, that capacity and development already. If that makes sense.
Okay.
Yeah, I can't read.
Yeah.
Thank you.
Okay, thanks, Jackie. Stephen.
Sorry, I was just going to bring us back to the risk and say the risks about whether practices have adjusted adequately, and I think that they have. So it's looking at the likelihood. So the likelihood of them not is probably going to be a lot lower now. So I just wanted to bring us back to that, because that's what Steve was hoping we do, I think.
Right. And
having,
sorry. Sorry, Stephen, go ahead.
Sorry, I was just going to say, and having been seconded into vaccinations and all that work around primary care, I've got first-hand experience of how practices have adapted.
Okay, thank you. Will.
There's two points. The first one is about infection control and management in practices now. That is an unknown risk, simply because things are about to change very dramatically as of tomorrow, and we don't quite know how that's going to hit all healthcare services, not just primary care. And testing, you know, we've been told that we're not going to be able to access tests until we found out last night that we are going to be able to, but the rules come in tomorrow night. So I think that the healthcare service at large is being somewhat hung out to dry by central government, which leads me on to my next point, that when it comes to the relationship between PCNs and the CCGs, what we hear from practices is that the COVID vaccination programme and the way in which they have worked with CCGs generally, but specifically with Portsmouth as well, is that it's brought CCGs far closer to practices, and it's improved relationships dramatically, and that CCGs are negotiating very powerfully on behalf of practices with central government and with NHS England, actually pleading primary care's corner. Unfortunately, that's where the disconnect lies. So I think in terms of a risk between CCGs and PCNs, actually that risk isn't there. It's more the risk of CCGs actually having to negotiate on behalf of primary care and primary care networks with central government. That's where the disconnect lies. So I think practices are grateful for the work that the CCGs have all done on their behalf.
Yeah, it's useful to know. Thank you.
Yeah,
but
thanks.
Not sure what we can do about the disconnect, Wills. Okay.
So if I just bring us back to the risk register again, Margaret. So the one around practices adjusting their services, I do think they've done as much as they can, but I think that risk is still there for other reasons. So perhaps we just agree to keep that under review for the moment.
Yes.
The only other one I wanted to focus on was the C081, I think it is, pressure on practices from delivering the COVID vaccination programme and everything else COVID related impacting on practice services. And I just wondered, just a question really, whether we feel we could lower that score as PCN's practices not doing quite as much on the COVID front as they were, and starting to get back to, well, they've never stopped providing core services, to be fair, but they're doing more and more in terms of catching up and delivering primary care services. So I'm thinking we could possibly reduce that one slightly.
Are people happy to reduce it slightly? To what, Steve, are you considering?
I was thinking maybe a 2 and a 4, possibly.
Okay. Are we happy to reduce it to a 4? That probably means if it continues to reduce, we'll take it off at some point.
Yeah.
Okay.
Yeah.
Thank you. Okay, thanks, Steve. Any other issues on the risk register? No. Okay. Can I then move to the finance report? And Nicola, who has joined us now.
Thank you, Margaret. The finance report. So would you like me to just walk through the highlights, and then I shall sort of move across to questions, if that's okay. Sorry, can you hear me properly, Margaret? It's breaking up a little bit.
Sorry.
Yeah. Okay. So in terms of the overall CCG position, we're on trajectory to deliver a break-even financial position as at this financial year end. As we have outlined in the summaries in prior months to the governing board, this is a movement from prior months where we had been projecting a surplus position, and that's as a result of working together across the Hampshire and Isle of Wight ICS to ensure that all partner organisations can deliver a break-even position in 21-22. Our position at the moment is contingent on the delivery of some hospital discharge programme monies, some additional roles monies, and some winter access funding money held centrally. The details of those you can find on sort of the summary financial performance slide. So you can see we're drawing down around £300,000 worth of central allocation for ours roles, and we're also expecting at the moment £100,000 worth of winter access funding, which contributes towards the primary care position for us. Moving closer into the actual primary care position, what we are seeing is since reporting of month 11, as you'll be aware, we are finalising that month 12 position now into the closing position for the CCG. So whilst the detailed primary care position does currently show full use of funding around the contingency held, what we will be doing is releasing that into month 12, as we haven't had significant calls against it to date, and working with across the whole primary care team, no particular liabilities have been addressed to us for that. As I say, we are drawing on some of the central allocation funding for our roles. This isn't the maximum that we could have utilised for 21-22. However, what we have seen is the recruitment against those posts increase as the year's gone forward. So we would expect the overall expenditure in ours roles into 22-23 to be much higher than we've seen in 21-22, and we have had confirmed that that central allocation to support us with that remains into 22-23 as well. One of the key things that we just need to remind ourselves of is the income protection that we've got against our practices for this financial year. So both the majority of local commission services and the direct enhanced services have been protected at pre-pandemic levels for the full year. And the team are working, the finance team and commissioning team are working together to look at what that activity looks like in terms of current year compared to the pre-pandemic levels, to ensure that we don't have any sort of seismic shifts in income certainty for anybody again in 22-23. They were just the highlights that I was going to pick out for you guys, so I'll sort of stop there and just see if there's any questions or comments.
You're on mute, Margaret.
Sorry. Nicola, it doesn't look as if there's any comments at the moment, so let's just continue.
Brilliant. That was me done, Margaret. Oh, so yes, I'd just like to ask the board to accept the report. Okay. Are people happy to accept this report? Jo?
Yeah, it was just really around the contingency and that is being released. Does that pose a financial risk to us, Nikki, or is that something we're managing and mitigating? It was just, I wasn't really sure.
So yes, so throughout the year, the CCG has been working closely with colleagues in primary care to be aware of sort of emerging risks and uncertainty. So we have known for some time that contingency may not be required in full due to the lack of risk across primary care. So the CCG has had parallel plans in place to utilise that funding across the population should we not require it to support the primary care position. So the money is not lost, and it is supporting other areas of expenditure within the CCG.
Brilliant, thank you, Nikki. That's what I thought, but I just wanted to double check.
Sure. Jackie.
Thank you. Mine was the numpty question. So on the table for the primary care, there's a number of zeros that are entered in the budget. So for LARC or leg group or ring pessary or deprivation and inequalities, which is the one that interests me most, is that because that was a block payment or it didn't happen, or quite?
No, so I think because this reports in millions, Jackie, they're just not registering as figures when they're sort of across those multiple lines. Were we to collect everything together, it'd start sort of kicking out numbers. So there's nothing in there that's been removed as a result of the block payments, and things like LARC as an example, without going into too much detail. That's only the cost of long-acting contraceptive that is not for a contraceptive reason, so it's for a medical reason. So the instances of that are few and far between. LARC as an actual contraceptive methodology is paid for via the local city council through their public health budget.
Thank you. That's really, really helpful. It's just not just with all the pressures. I hoped that these things just were still continuing as best as we could do, rather than. Thank you. Makes sense.
Okay. Any other questions on the finance? Okay. Thank you very much, Nicola. And, okay. We'll move on to flu and COVID vaccination programme. And Simon isn't here at the moment, but I think Chris, have you got information on this?
Yeah, so I'll update the group on flu. So I'm not sure who's updating on COVID, but I'll run through our latest flu figures with you all. So the latest flu data I have is up until the end of January. So I'm still waiting for our sort of latest figures to come through. But if I sort of break it down into cohorts, just to give you a bit of an idea of our achievements across Portsmouth. So age 2, we're at 54% achievement, and the target for that is 70%. Age 3, 57% achievement, and again our target is 70%. Age 65 plus, 83%, and our target is 85%, so not far off of that one. Age 50 to 64, 58%, our target is 75%. Under 65, clinically at risk group, we're at 58% and our target is 75%. And then for our pregnant people, we're at 43% and our target is 75%. Obviously, you know, as I said, this is end of January figures, and we have got a bit of a gap within some of our achievements. The COVID, the CVP programme has had quite a detrimental impact on this as well. So we have been working closely with practices across the city on more of a targeted, focused approach. So offering that support where we could. And I know conversations I've had with practices, they were going to sort of pick some of these areas up and really give a push in some of these areas, dependent on what their figures were as individual practices. So I'm hoping to see quite a significant increase in our next data set, which we receive. Also, our pharmacy colleagues, they have done a fantastic job with our flu uptake. There is actually an increase of 70% in comparison to last year's figures for pharmacy. So they have done a huge job around our flu vaccination programme. So they've made a tremendous effort with that. With regards to actually our achievement at a CCG level, so this is in comparison to our neighbouring CCGs. We sort of sit mid achievement, so we're not doing any sort of worse than anybody else, or we're not at the very top, but we're sort of in the middle there. So we have done really, really well in comparison with our other colleagues. And as I said, practices keep sort of pushing. They've been doing a huge amount of work around this programme. So as I said, we're just waiting for the end of year data to come through to see what our final year achievements are in this. We're also going to be carrying out an evaluation, so a review of how we've got on this past year, what has been the learning, so what hasn't worked so well, what has worked well, and making sure we're going to be sharing that as well across Hampshire Isle of Wight, so with our neighbouring colleagues as well. And we're also planning now for our 22-23 flu programme. So our practices have been ordering their stock for the next flu season, and just starting to plan that out as well. And then, as I said, looking at those learnings and maybe what we can do a little bit differently as well next year. Okay, I hope that's helped. And has anybody got any questions at all?
Any questions on what Chris has been reporting? I have a statement from Simon, which I will read out. The spring booster campaign is going ahead with, that's for the COVID vaccinations, with all primary care networks participating. And the vaccination programme for 5 to 11-year-olds has commenced and is being offered from 3 of the primary care networks. The mass vaccination site at St James's is also being used for that COVID vaccination programme for 5 to 11-year-olds, as are the pharmacies, Lally's and Goldcam. And Simon's also commented that preparations for the flu vaccination in the autumn are underway, so that there's a planned September start for that. Are there any other comments that people want to make in relation to Roger?
Yeah, thanks, Margaret. I was just going to ask about the spring COVID boosters, whether that's just 4 or 4 and 5. There's been some sort of media attention about people having a 5th booster, and I'm just wondering if we know where that's at. I've seen a few stories in the media, but nothing kind of substantive. So,
is anybody in a position to answer that one?
Yeah, so Roger, I think for it's generally a 4th dose for the over 75s. I think the confusion may possibly have come with the immunocompromised who've had an extra one in there somewhere. So the 4th spring booster is for the over 75s and is going ahead. Does that clear it up for you?
No.
Okay, what else specifically did you want to know?
Well, it was about those that are immunosuppressed, whether they will be getting a 5th, because that's what all the media stories were. You know, some people have had their 4th, and it's just whether there is a 5th pending. It might be a national decision, Sylvia, but it's just...
I think it is. I don't think we've got any direction on that as yet, but I will try and find out.
That would be lovely. Thank you. Thanks, Margaret.
Thanks very much. Any other comments or questions on the vaccination programmes? No. Okay. Can we then move to the next item on the agenda, which is the winter access funding? No, sorry, it's Primary Care Commissioning Committee Scheme of Delegation. Steve.
Oh yeah, thanks, Margaret. So we've just updated recently our scheme of delegation. There were only some minor tweaks made from memory, but we thought we'd bring it to committee just to make sure that everyone is kind of in agreement with how that's set out in terms of our decision-making processes. Majority of it is Primary Care Commissioning Committee, along with the Deputy Director or Head of Primary Care that makes most of the decisions. It'd just be nice to get this kind of signed off or deal with any queries or issues now before we go across to the ICS in July, really. So happy to take any queries on that.
Any? Nicola.
Thank you, Margaret. Just picking up on your last comment there, Steve, around getting this approved prior to sort of moving over to the ICB post July. How aligned is this with CCG's scheme of delegation?
It's a good question, Nikki. I haven't seen the Hampshire Isle of Wight version of this, so we would certainly look to align as close as we can with it, obviously come July, or move across to their version. So yeah, we can look at that next, I guess.
Okay. So can we make sure that's done then, Steve? Yeah, because it does obviously need to be aligned. Yeah. Okay. Roger?
Sorry, it feels like I've come alive suddenly, Margaret, with lots of questions. So mine was about the closed lists and the applications for closed lists, because we seem to at Healthwatch Portsmouth have received a number of comments from the public about people going to their or going to a GP surgery to register and being told that they're not accepting patients. And I see that it's a delegated function and it goes through the contract review group. But I'm not sure we've ever seen any details of that, and I'm wondering whether this committee needs to. So that's a kind of a question and a comment. Thank you.
Yes, so you're right, Roger. It goes through our contract review group to review any list closure applications. We don't have any list closed at the moment in Portsmouth. In fact, we've taken an approach whereby we're pretty much discouraging list closures because of the knock-on impact potentially on other practices. So we've got one practice with a soft informal arrangement with another practice within their PCN. But other than that, there's no actual formal lists closed at the current time. Just going back to the scheme of delegation, yeah, I think you're right. I think that one does just get signed off at contract review group. Come to committee, I think.
You need to check that, Steve?
I'll look on there now.
So people's experience, Steve, is that they are finding GP surgeries are saying they are closed, as you know, because we've sent some emails in about that. And people being removed from lists, but this is closed practices. So I'm just wondering if we need to have sight of that as a committee, because that's a big impact on people if they're going to register, being told they're not, and then we chase it up and people tell us, oh no one's closed, they're all open. So there's not a degree of transparency, it feels there.
Yes, I've just found it on the scheme delegation. So currently it goes through contract review group, and then that group makes a recommendation for head of primary care or deputy director to make a decision. But it's a kind of a separate issue as to patients being told that a practice has a closed list, because actually we don't have any other than that informal arrangement. So that is kind of a separate issue that we would have to deal with as and when we hear about it and follow up on that, really.
Yeah. Okay. It does feel like there might need to be some discussion about how that gets, what processes we use to do that. Okay. Perhaps that's something we can look at. Yeah. Okay. Linda, I think you were next, and then Joe.
Thank you. Yeah, I mean, I agree with Roger having some sort of oversight. So I agree that the decision needs to be made quite rapidly. When a practice asks for it to close the list, it needs to be done sooner rather than later. So the contract review group could do that. But whether then when we have our meetings, if any have been closed, that you bring it to us just for our information, not for us to make the decision.
Yeah.
Yeah, and of course the minutes from the contract review group do come to this committee, so it would feed through that.
Yeah, maybe just highlight that when you're then going through those minutes, then just so that we're aware.
Sure.
Thank you, Linda. That's helpful. Joe.
Yeah, I would agree. I think that's quite a good idea, and just highlighting it if it's already in the minutes so people are aware, that'd be really helpful. I think my other point was more related to Nikki's question, and I think the reason we had to do this was because we've had quite a lot of changes in the primary care team and structure over the last sort of 2 years. We needed to be really clear what those scheme of delegations were and where they've changed. But I think you're absolutely right, Nikki. Now that we're clear what we think works and works in our structure, we absolutely do need to align that with the Hampshire, Southampton and Isle of Wight CCG, because I think their primary care commissioning committee is sort of much bigger, and therefore they would see a lot more delegated to like a primary care operational group in the locality or at place. So we might just need to look at that in light of that as we move forward post July.
Yeah, I'll take that up with my primary care lead counterparts in other parts of Hampshire.
Brilliant, thank you, Steve.
Thanks, Steve. Jackie?
Thank you. I just wanted to go back a little bit to the closed list and agree with all the comments that have been made that perhaps it does come to primary care, but I did notice in the minutes of November that it has said that one of the medical centres does have a closed list, but I don't know if that's changed since then.
Yes, we did have one with practice with a closed list, Jackie. That's now reopened again.
That's reopened. Thank you. And that was, yeah, just get clarification on that, and completely agree with the comments that I've made prior to that, that perhaps it comes to here in some way or highlighted. Thank you.
So I think what we've agreed is that there should be information on closed lists coming to us for information after the contract review group have made decisions, and that we will align this proposal with the Hampshire and Isle of Wight proposals on this, on the delegation. But subject to all of that, are we happy to agree this? Yeah. Okay. Thank you very much. Okay. Shall we then move to winter access funding? I think that's you again, Steve.
Yes, thank you, Margaret. So just wanted to give a brief verbal update on the winter access funds. So we had £360,000 for a local incentive scheme, which was agreed across Hampshire and Isle of Wight. So we're all working off the same scheme. And then there was another 229,000 for targeting variation. So in terms of the local incentive scheme, that's been predominantly used for providing additional capacity. So we've had lots of practices putting claims in for additional hours undertaken by existing staff. Some practices managed to get locums in, GPs as well as nurses. And significantly, we invested a lot of money into Push Doctor, which we've spoken about previously at committee, the remote consultation service. On top of that, there was a separate fund for innovation and equipment. So lots of practices have put in bids for some kits, things like pheno machines for testing for asthma diagnosis, patient pods where patients can take their own blood pressure readings, etc. And things like a pathology tool, which allows for a more efficient process for pathology results. So various initiatives that have helped support improved access and additional capacity over winter, which without any of that, I think would have been in a much worse place. So that winter access fund was very welcomed in the end. It was a little bit controversial at the beginning, the way I think it was announced nationally, but locally, I think across Hampshire and Isle of Wight, we've managed to make that work. In terms of the targeted funding, we've mainly used that for Push Doctor for practices that were really in need of that extra resource. So that was targeted at certain practices that needed that. We've also invested some of that money into the health inclusion service for the homeless patients as well, targeting services for homeless patients. And then finally, just in addition to that, there was a separate security fund as well. And we've made full use of that scheme as well, used all the money for that. And that's mainly gone on things like CCTV and safety glass in reception areas, things like that, which have made things safer for practices. So all in all, we've spent almost all of the money come year end, and it seems to have gone to good use. So hopefully it's helped make a difference.
Okay. Any questions on that? Any comments? A bit of positive news. Thank you. Thanks, Steve. Can I then move to the specialist clinical pharmacy team? And Jill, I think it's, yeah, thank you.
Hi there, I'm going to share my screen if I can. It takes me a while to do this, so apologies. Okay, can you see that?
Yes.
Fab. So I'm Joanne Williams. I'm an interface formulary pharmacist. I'm a member of the Meds Optimisation team. I had hoped that Simon would be here to present, but unfortunately he's away today, so you've got me, unfortunately. Okay. So primary care practitioners are increasingly treating patients with expensive and complex medications, previously only considered for specialist use in secondary care. The Carter report highlighted the need to invest in pharmacy workforce to drive optimal value and outcomes for the £6.7 billion of NHS investment on medicines. Although this report focused on secondary care, with the move to push specialist medicines into general practice, it is now reasonable to extrapolate the findings of the report to primary care settings. Prescribing of medicines is the most common intervention in patient care and the second highest area of spending in the NHS after staffing costs. Medicines are associated with a high degree of clinical and financial risk. For Portsmouth CCG, the spend on medicines is around £64 million per year. This is expected to continue to rise as the number of patients living with long-term conditions increases and with the emergence of new treatment options, which are often more expensive. Clinical pharmacists are increasingly working as part of general practice teams. They are highly qualified experts in medicines and can help people in a range of ways, including conducting structured medication reviews and improving patient safety, outcomes and value through a patient-centred approach. The NHS long-term plan commits to increasing the number of clinical pharmacists working in general practice, making it easier for patients to access the right expert health professional for their needs. The 5-year forward view sets out the vision for the future NHS and states that long-term conditions are a central task for the NHS. This is particularly important with the increasing number of patients living with more than one long-term condition, people living with frailty and with complex needs, as well as those in the last 12 months of life. A source of recurrent funding has been identified, and it is proposed that a team of clinical pharmacists is employed by the CCG to support primary care as experts in specific clinical areas. Patients at the interface of care are at high risk of medication-related errors and harm. Numerous studies have described medicines as a source of hospital admission, with the average rate of 15.4%. Amongst hospitalised patients, 2.7% died due to drug-related harm. Drugs that are frequently reported as causing drug-related admissions were blood thinners, medicines for blood pressure, pain, diabetes, mental health, and for cancer. Polypharmacy, older age, and female sex were mentioned as determinants for drug-related hospital admission in a number of studies. Approximately 1/3 of drug-related hospitalizations were considered avoidable, and more than 40% were potentially preventable. 10% of patients with dementia are prescribed an antipsychotic in our area. If we were to reduce this rate to prescribe at the England average, there would be approximately 120 less patients with dementia being treated with antipsychotics, which is a combination which is not recommended. This proposal is to establish a team of 7 local specialist clinical pharmacists. The team will be employed by the CCG to interface with the specialist teams in Portsmouth hospitals and Solent. The pharmacists will work predominantly in primary care in patient-facing roles, running clinics as prescribers trained in advanced history taking and physical assessment. They'll lead on population health initiatives on behalf of the CCG, in addition to supporting training and development for the local PCN teams, and act as a point of referral for more complex patients. The benefit of employing these pharmacists at CCG level, it enables them to work across the geography of all PCNs and link in with the specialist teams within provider trusts, supporting patients transitioning between services and providing a source of mentorship and clinical supervision for the actual specialist pharmacists. This proposal has been discussed and has support with lead pharmacists within Portsmouth hospitals, Solent and our counterparts over in South East Hants area. These 7 clinical areas have been selected as they're areas of both national and local priority. These are also areas with most commonly linked with drug-related hospital admissions. If I show you our local data. So this table provides data from EPACT. It shows the number of patients dispensed medication by Portsmouth primary care prescribers for the last 12 months. The cost of medication and the number of prescription items is also included to show the potential burden for patients requiring medication in our locality. Southampton CCG employ a pain pharmacist who's kind enough to share her job evaluation. She evaluated her role at 9 months. Her role is to support primary care, but she interfaces with the specialists within the chronic pain team at Solent. This model is how we envisage the team working with their specialist areas. This is a summary table showing interventions made over a 6-month period with just 30 patients. Many patients have managed to stop their opioids altogether. This is a table showing local data. For Portsmouth, we are unfortunately a very poor performing area for prescription of pain medication, and one of the highest in the country. So this shows for patients prescribed 5 or more analgesics. So for Portsmouth, for patients who start on regular analgesia medications, they end up on 5 analgesics, which is really not good. This table provides a summary of the costs for employing the 7 clinical pharmacists. As the proposal seeks to almost double the size of our current medicines optimisation team, we'd like to employ one of the members as a team lead, and they'll manage the team and develop the service. The proposal seeks to directly employ the pharmacists within the CCG, but if this is not possible, we would look to have an organisation such as the Primary Care Alliance to hold the pharmacist contracts, and this may incur a cost. Training costs will be dependent on the experience of the individuals who are employed into these roles, and may reduce if we're able to employ pharmacists who are already in possession of a prescribing qualification. It's a summary of annual and one-off costs. In terms of timescales, job descriptions and workforce control panel forms are ready to go to the relevant committees for approval. The evaluation from the Southampton pain pharmacist highlighted it takes a significant amount of time to get these types of posts up and running, embedded in both primary and secondary care teams and making an impact on patient care. Additionally, if the successful applicants also require training to become prescribers or to undertake physical assessment, this would take additional time, which minimally would be expected to be at 6 months. So it's likely that the impact of this roles would take up to a year to be realised from the date of approval. We've got options, obviously. We've got the do nothing. So obviously not taking up the opportunity to use the funding that's been identified to support the population. We could pilot a smaller team or consider employing on short-term contracts. Piloting a smaller number of posts or short-term contracts would mean areas of identified risk will not be prioritised. Short contracts may lead to posts remaining vacant and the team not being fully established prior to the review or termination of their contracts. So we'd like to get the posts fully funded, so all 7 identified areas are a clinical and financial priority, as it will take the time for the post holders to establish their roles within primary and secondary care teams. So requested that all posts are supported by the committee as permanent positions. And the committee is asked to approve the request of the specialist clinical pharmacy team with associated funding.
Okay, right, Jo. There's a question from Linda.
Yeah, I was expecting lots of questions.
Yeah, no, thanks, Jo. I mean, it sounds like an interesting idea, and I think the posts would be welcomed. But what's the reality of filling these posts? I mean, PCNs are struggling to recruit pharmacists. I know, obviously, we recruit them into practices as well. Pharmacies need them. So, what is, if we were to approve this today, how confident are we could get this workforce?
I think in reality, I suspect we'll be having to do several rounds of interviews. The likelihood of getting 7 posts all at one go is minimal. I am aware of people who potentially would be interested in the role, so I suspect we'd be able to recruit at least 3, if not more. But like you say, the pharmacy workforce needs to be established. We haven't got 7 people waiting for these jobs. Whoever we do employ would likely need to be trained up as well.
Jackie?
I'm going to follow on a little bit from that, is that the spec or the sort of job description that I can see for this post is quite extensive, actually. You're going to be patient facing, you're going to be leading training, you're going to be the point of contact for more challenging cases. It's a lot. Is that going to be attractive to people? Is this what the person in Southampton is doing and that fits comfortably within their capacity? And the other thing, which might be a very quick one after that, is I can't get the number to add up, so Nikki might come in there.
Okay.
But yeah, in terms of the breadth of work that's being asked here.
It is a big breadth, like you say, it is based on the Southampton pharmacist, so working in specialist clinics, seeing patients, so they'll do some of the patient identification instead of how our team normally works. So we would potentially do a piece of work looking at, say, a cardiovascular area, and then pass that work back over to the GPs. We would expect these pharmacists to actually be undertaking that role as clinicians in their own right. The education part would be a small part of their role, so helping to support some of our new PCN pharmacists potentially, or specialist nurses. So it's in parts. So if they're doing a clinic, say, within a particular PCN, they may well be able to do some of that training by having some of the PCN pharmacists go in to do some shadowing with them. They do, say, presenting at our GP prescribing event. So it wouldn't be a day every week potentially doing that. It'd be predominantly very much patient facing.
Okay, and then in terms of also being signposted the more complex cases as well as running their own clinics, is that also something?
Yeah, so it would be dependent on how they are finding their patients. So it might be that we do a clinic looking at patients, so the respiratory pharmacist looking at patients who are using a lot of their treatment medications, so their blue salbutamol inhalers. So they would potentially be the people doing the fact finding, so actually trying to organise those appointments themselves and prioritising those patients. But the more complex patients, they would have the higher priority.
Thank you. It seems a bit, especially if we haven't got a workforce that's banging at our door to get into it. But thank you. And the costings, I think Nikki will pick up because I can't.
Okay.
Nikki, can we?
Thanks, Margaret. So yeah, so my initial comment was going to be that we need to work through this costing, because I don't think it's been done by the finance team. It doesn't add up, and we're setting things like training a one-off cost. So I think we need to think about that, because whilst it might be one-off as a setup, we would absolutely need to keep the team skilled, etc.
Yeah.
So we can look at that side of the meeting. But my question really was more around the evaluation. So you really helpfully shared sort of the work that the Southampton team had got in terms of outputs, and you talk about sort of it may take up to a year to evaluate. But can you tell us a bit more, Joanne, about sort of what the expectation is in terms of how would we know if we'd achieved our goal through the evaluation? I'm not sure I could see that clearly through the paper and the discussion so far.
So in terms of the evaluation, I think it will very much depend on the clinical area the pharmacists are working in. So it would be in terms of, I can't remember what the KPIs were that were linked to the Southampton role off the top of my head, but we'd certainly look at fixing KPIs and then doing an evaluation based on those.
I guess if I was a bit more blunt in my question,
yeah,
are we working on a proposal that we expect this to provide cost savings and therefore neutralise the cost of the investment, or is this more of a quality scheme?
For me, it's quality. There will be an element of cost saving. So certainly when they're doing the CCG part of the role. So in terms of some of the population health, so things like for the cardiovascular pharmacists, we've got and there's a national rebate looking at edoxaban. So they would be supporting some of the potential switches if we were going to go down that route.
Okay, thanks, Jo.
Will?
Hi there, thanks. Joe, you know some of my concerns about this,
Yeah.
and just to share them generally, is that this, to our perspective as primary care practitioners, is that this feels quite focused on secondary care. But I know you've reassured me that actually this is intended to be focused more towards primary care, and it should be supporting primary care. But I think perhaps the service specification needs to say that, because when the pharmacists arrive in practices and in the community, there is a risk that they will have read the job description and become more focused themselves, especially as some of them may be coming out of secondary care. And when you get any new member of staff walking into a primary care setting, they often look like rabbits in the headlights. They are petrified. They look at GP lists and go, how can you do that? How can you have 80 patients on an urgent care list that's being delivered by 2 people and you're asking me to help you? And they walk away very quickly. So
I was one of those farm staff.
The churn of staff, especially amongst pharmacists and pharmacy technicians, is well recognised at primary care networks, and we need to be very careful that you don't spend a huge amount of time employing these new members of staff only for them to go, oh my God, this is terrifying, and walking away, because that takes a lot of time and effort. The process of employment, the process of embedding them into primary care, and then they leave. So you need to be careful you get the right people.
Absolutely.
And I think one of the risks of this particular service, because you've given them specialist pharmacy roles, I'm a specialist in LD pharmacy, is actually you are by definition one step removing them from primary care, because you've specialised them, and primary care is a generalist service. So there's very rarely a patient who just has cardiovascular needs with complex pharmacology problems. They're very much more likely to have cardiovascular needs and respiratory needs and mental health issues. Because those things all go together. And the example, case in point here, is a pain management pharmacist is very nearly always subspecialising in mental health practice as well, because those two are so inextricably linked, chicken and egg. And so I think we need to be very careful with this specification, that it defines the role as facing primary care. It's not telling people how to do the job and saying, well, GPs, please do this, and that the flow of information between these specialist pharmacists and primary care needs to be very carefully thought through, so that it's not a please will you do this by letter and then please will you do that by response from the GP because I haven't got capacity to do it. Where PCN pharmacists work well is when they're really well embedded in the practices and there's a flow of information, there's tasks between them within the IT system, and that little bit of the provision, the actual nitty-gritty nuts and bolts of how it works well, will make this efficient and make it work well. I think, however, there are real positives in this, because you've recognised some of the weaknesses in PCNs currently, which is supervision and mentorship. GP PCNs are really struggling with mentorship of pharmacists and all the other Rs roles, and this team would be a fantastic team to help with that in PCNs, and to be able to help pharmacists as they enter to help bring new pharmacists into primary care. So I think that is a real positive. So you would absolutely have our support, and I know you've absolutely reassured me with some of your comments that you sent back to me personally about the things I've just raised, so thank you.
Yeah, just to say, like I said, I was a secondary care pharmacist who moved into a GP role, and I was unfortunately one of those ones that did move on from that. But I do appreciate the fact that, these are big areas and there are big asks, and actually we do need generalists as well as specialists, which is part of the reason why I was saying about having these complex patients potentially referred into. So you'd have your PCN pharmacist potentially seeing these patients and being like, actually I need some support reducing this patient because they're on high dose, high risk opioids potentially, and then just managing them along that. Like you said, we're hoping to employ them as a team. So also in terms of having a opioid pharmacist, they'll have those links across again with a mental health pharmacist. So if they're looking, saying, I've seen this patient one, I think that part of the issue is some of the mental health aspects. Can you see them as well, or can you get advice from them? So we're trying to hope, it's going to be a linked up service. It isn't just going to be these people working independently. I do appreciate the concern that we're saying they're specialists and linking with secondary care, but it is more to get those expertise out of secondary care. We don't want them doing secondary care work.
Okay, Thank you. And Joe, the last question, last comment.
Thank you. Yeah, and I think thank you, Joe, for your presentation. I think you know, that was really helpful, and I really understand the ambition of this and trying to address an area that is a kind of an ongoing challenge really around medication and medication review. And I think to some extent my question follows on from Will's and Nikki's, and probably two questions really. One is, and you possibly answered some of this already, how this team will work with our current MedSop team and the primary care team, and is there a risk of duplication in some of that, and do we need to be really careful how we manage that? And then the second question, I think I would just echo Nikki's point that we probably do really need to understand more about what will good look like and what's the evaluation before we embark on this, so that we're clear, particularly both the quality and outcome savings, because there's clearly some huge things to be gained with the number of people on complex opioids, but also where the cost savings are around that, and how you prevent those avoidable emergency admissions as well because of medication. So I suppose they were my 2 points. How do we make sure it's not duplicating? And we would need a really clear evaluation, I think, of what we would test this against.
Yeah, so in terms of the cost evaluation, I'm conscious some of these roles will have a bigger impact than others. So in things of, say, opioids, they're actually relatively cheap to prescribe a lot of these medicines. So that is really, as much as we will be saving some money if we manage to stop those medicines, it's going to be relatively small numbers. The main impact in that is the quality and actually reducing risks and potential deaths associated with prescribing those high-risk drugs. Duplication, absolutely, I completely appreciate that. My husband's a care homes pharmacist working over in a different patch, and often he'll be seeing a patient who's just been seen by somebody else. So actually, we don't want to be duplicating work. We really do need to be focusing on seeing these patients who need our help, not those sort of, you know, the day-to-day ones. It's the more complex ones that we really need to be supporting.
Okay, can I just try and summarise where we've got to on this, because I think we've got questions around cost which need to be sorted out with the finance team. We've got issues around how realistic it is to attract these post holders, but I didn't hear too many questions about the ideal being that we have a team, and we go for that if we go for anything. But it feels like there's more work to be done on the spec to make sure that it's clearer what we're in the proposal, that it is about a link to primary care and not secondary, and some of the advantages to primary care of that and to the patients. Yeah, so it does feel like there's a bit more work to be done, but that in this committee at least there's some interest in seeing this move forward. Yes? Does that make sense? I don't think we make a decision today because we haven't got the information we need for that, but if we can do it on that basis, is that okay? Yep, okay. So please we do think there's more work needed, but we'd like to see this come back to us. Thank you.
Okay, thank you.
Okay, can I then move to general practice contract?
Yes, thank you, Margaret. I'm conscious of time, so I'll whiz through this quite quickly and just pick out a few key things. The emphasis from NHS England seems to be more around provision of COVID vaccination support on a smaller scale from practices than previously, and with more of a focus on non-COVID needs. I think if you spoke to some of our PCNs and practices, they'd probably feel they could still play a major part in the vaccination programme and do, you know, the core GMS work. But there seems to be more of a focus on the non-COVID needs. I think there is going to be a big focus on access one way or another this year. It's in the quality and outcomes framework in one of the quality improvement domains, so there'll be some work for practice to do on that. I believe CQC are going to be having a bit of a focus on access as well, and they're currently in the Portsmouth area. And across Hampshire Isle of Wight, we're just commissioning a new demand and capacity tool, which might help support practices with some of that work, as well as helping the Commissioner from our side of things. And alongside that tool, there'll be an offer of some support to go into practices, if that's what practices would want, to help actually review some of the information, the data, and look at where there could be some efficiencies and that sort of thing. So there will be an offer to go alongside that tool if that's what's needed. In terms of QOF, income protection obviously ends, but no new indicators, so that's quite welcome. Having said that, I think it's fair to say practices, CCG, LMC, not overly happy with certain indicators in the QOF, childhood IMS being the main one. So we're trying to push back on the targets associated with that, because it's quite unfair on practice, I think most of us would say. More money going into the additional roles reimbursement scheme, which is always welcome. Not only one of our PCNs has actually managed to fully utilise the R's funding, so we'll be looking to support other PCNs to try and use more of their funding, but certainly the money is there to use. And many PCNs are reporting that a lot of those additional roles have made an impact and have been very helpful. The biggest news is probably the amalgamation of the extended hours that PCNs provide through the DES and the extended access service that's commissioned by the CCG and delivered by the Alliance. So from October, that will be combined and will be a PCN requirement. And we need plans in place by July at the latest. So that's actually being discussed on our commissioning evening tonight. So we'll see how those discussions go as to how that might pan out. So that's really useful that we've got that on the table to discuss tonight. But we await the finer detail on some of this over the next coming weeks, and we'll obviously work with our local practices on any issues that arise.
Okay, people are happy to note this at this stage? Will.
Thank you. Very quickly, because I'd like it to be noted that this is a contract that's been imposed on general practice by the government, by NHS England. It isn't a contract that's been accepted by the commissioning organisation, by the negotiating organisation, which represents general practice, and that most GP practices are unhappy with it. This is based on a contract that was negotiated before the pandemic, and it doesn't recognise the current cost of living, as is often the case in all walks of public life at the moment. And therefore the uplift in the contract payment does not meet the potential uplift in the needs of all of the people that work in general practice, from the doctors all the way to the reception teams, and therefore they are going to be losing out on potential pay uplifts in the real world. Thank you.
That sounds like yeah. Jo.
Yeah, thank you. It was just very quickly to flag that I think that the DES is quite a risk to our integrated primary care service and how that functions, and the CAS provision as well. So we will need to bring that back to this committee for decision, and we also have to make some quite quick decisions around the ongoing procurement of that service, because we've been delayed in doing that because we've been waiting for the DES. So there is a potential risk to us around that, and I think tonight's meeting will be really helpful to get a view as to where practices and PCNs are and how we can move forward, hopefully quite sensibly and pragmatically, to retain as much of the service in the short term at least as we can. So that buys us some time to think through future plans, really, is what I'm saying.
Okay, it does sound like we need to bring this back with something about the implications of whatever is decided on this for our services, and understand the impact of this on what's as we go forward. So can we bring that back to the next meeting? Is that okay, Steve? Yeah. Okay, with a bit more time to have that discussion. Yes, thank you. Thank you very much. Can I then move to the ratification of the chairperson's actions? And I'm just going to assume that you're not going to leave me without ratifying the chairperson's actions on contract variation for Lighthouse Group and on the change from personal medical service to general medical service for Portsmouth Group. People happy to just agree those? Thank you. Okay. Can I then just ask, I don't think there's any other business being registered, but I will just say that the date and time of the next meeting, just to remind you, is Wednesday, the 8th of June at 1 p.m. Okay, thank you very much. We've just about made it to 11 o'clock. If there's no other business, Jackie, did you want to flag something?
Just a quick one. I'm kind of aware that the 8th of June is probably going to be our last PCCC in this format, I guess. That was all. And then hopefully so we'll have probably quite a lot of work to do and a lot of thanks as well, especially to you, Margaret. But yeah, that could be our last meeting. Just flagging that.
It could be. It depends on a white paper going through. Yeah. Okay. Thank you. Okay. Thanks very much. Okay. Thank you very much for your attendance. I'm going to close the meeting.